Hello, everyone, and welcome. This is a presentation for Yorkville University's Practicum 7113. I'm Julie Partridge, and I'll be presenting on Understanding Trauma-Informed Care, Approaches for Healing and Resilience. Before we start, I just want to acknowledge that this presentation was created and presented on the unceded, traditional, and stolen lands of the Syilx people, where I am a settler guest working, living, and enjoying this amazing valley. This presentation provides an overview of trauma and trauma-informed care, outlining how trauma affects individuals and systems, and how trauma-informed approaches respond to these impacts. It introduces the core principles that guide trauma-informed practice and reviews key evidence from the literature supporting their use. The presentation also explores practical applications across counseling, education, and community care settings, while highlighting important ethical and cultural considerations. Finally, it discusses implications for trauma-responsive practice and invites reflection and discussion through Brightspace to support integration of learning into professional practice. When we talk about trauma, it's important to remember trauma isn't defined by the event, it's defined by the impact. Trauma overwhelms a person's nervous system and sense of safety. Whether trauma is acute, chronic, or complex, it shapes how people experience their bodies, relationships, and the world. Trauma is stored not just in memory, but in physiology. Trauma can arise from many different experiences, not only extreme or catastrophic events. It's defined less by what happens and more by how overwhelmed, unsafe, or powerless someone feels in that moment. Trauma may begin early in life. Complicated births, medical procedures, or separation from caregivers can stress a developing nervous system. War, displacement, and chronic exposure to danger can create lasting hypervigilance and fear. Natural disasters and accidents often shatter a person's sense of safety and predictability. Grief and loss, especially sudden or traumatic loss, can also overwhelm coping systems. Interpersonal harm, such as physical, sexual, or emotional abuse, are particularly impactful because they involve betrayal by someone meant to provide care. Neglect, though quieter, can deeply affect attachment and self-worth when basic needs go unmet. Community violence, bullying, discrimination, and other harmful experiences can create ongoing stress. Ultimately, trauma is about the nervous system's response. Many behaviors reflect survival adaptations, inviting compassion rather than judgment. Research consistently shows that trauma exposure is a widespread human experience. In global population surveys, around 70% of people worldwide report experiencing at least one traumatic event in their lifetime. People also commonly experience multiple types of trauma over the course of their lives. Not everyone who experiences trauma goes on to develop a diagnosable stress disorder, but many people do experience substantial distress. Acute stress disorder, a short-term stress reaction occurring in the first month after a trauma, affects a significant portion of trauma survivors, with studies reporting prevalence estimates ranging notably depending on trauma type. For longer-term reactions, PTSD is the most studied trauma-related disorder. Global epidemiological study data suggest that about 5.6% of people exposed to trauma develop PTSD in their lifetime, which corresponds to roughly 6% of the general population. Among children and adolescents who have experienced trauma, research estimates that approximately 12 to 20 develop PTSD, depending on diagnostic criteria and the development of traumatic exposure. Importantly, although most people exposed to trauma do not develop PTSD, many still experience distress, anxiety, depression, difficulty with relationships, and other long-term effects, underlining why trauma-informed care is relevant for broad populations. But let's have a closer look at children in trauma. Childhood abuse and neglect are far more common than most people realize. Because these experiences often happen behind closed doors and carry shame or secrecy, they can remain invisible, which is why Bessel van der Kolk refers to childhood trauma as a hidden epidemic. Importantly, trauma is not limited to any one socioeconomic, cultural, or family group. It occurs across levels, education, and communities. The myth that abuse only happens in high risk or dysfunctional families can prevent us from recognizing how widespread it truly is. Large population studies, including the Adverse Childhood Experiences Study, or ACE, show that childhood adversities such as physical abuse, sexual abuse, and emotional neglect, caregiver substance abuse, and exposure to domestic violence are remarkably common. In fact, most adults report at least one adverse childhood experience, and many report several. We now understand that these early adversities are not just difficult memories, they have lasting neurobiological and physiological impacts. Chronic stress in childhood can shape the developing brain, stress response systems, and attachment patterns. This can increase vulnerability to PTSD and complex trauma, depression and anxiety, substance use, relationship difficulties, chronic health conditions. And so, childhood trauma also raises the likelihood of later trauma exposure, partly because early experiences can affect boundaries, safety, and relational dynamics. When we talk about trauma informed care, we're not talking about a small subgroup of clients. We're talking about something that touches a significant portion of the population. Recognizing this helps approach all clients with greater sensitivity, curiosity, and compassion rather than assuming resilience means nothing happened. So, trauma informed care shifts us away from asking what's wrong with you and toward what happened to you. This reframe reduces shame and increases compassion. At its heart, trauma informed care is not about doing more, it's about doing things differently in ways that help people feel safe enough to engage, reflect, and heal. The U.S. Substance Abuse and Mental Health Services Administration outlines 6 core principles that guide trauma informed care. These help us translate compassion into practice. Safety is foundational and includes physical, emotional, and psychological safety. People need to feel protected from harm, respected, and not judged. This is communicated through consistency, boundaries, and attuned presence. Trustworthiness and transparency mean being clear about expectations, roles, and decisions. Trauma often involves betrayal or hidden power, so we build trust by being honest, predictable, and open, especially when things are uncertain. Peer support recognizes the healing power of shared lived experience. Connection with others who have walked similar paths reduces isolation and reinforces hope. Healing doesn't happen in isolation, it happens in relationship. Collaboration and mutuality challenge traditional power hierarchies. Rather than expert knows best, we work with people as everyone brings wisdom to the table, and healing is a shared process. Empowerment, voice, and choice focus on restoring agency. Trauma removes choice. Trauma informed care gives it back. We support strengths, invite consent, and honor each person's right to make decisions about their own care. Finally, cultural, historical, and gender responsiveness asks us to widen the lens. Trauma does not exist outside of systems. We must acknowledge the impacts of colonization, racism, sexism, and intergenerational trauma and adapt care in ways that honor identity, culture, and lived experience. Together, these principles remind us that trauma informed care is not a technique, it's a way of being. Trauma informed care, through what are called the 4 Rs, guide individuals, organizations, and systems through trauma awareness into everyday practice. The first R is realize. This means realizing the widespread impact of trauma and understanding that trauma affects people across all settings: mental health, healthcare, education, justice, and community spaces. It also means recognizing that trauma impacts not only clients, but staff, families, and systems. Recognize. Here we learn to recognize the signs and symptoms of trauma. These may show up as anxiety, withdrawal, aggression, difficulty with trust, emotional dysregulation, or physical health issues. Instead of asking what's wrong with you, we begin by asking what might have happened to you. Responding means integrating trauma-informed principles into policies, practices, and interactions. This includes using regulation strategies, offering choice, being transparent, and fostering collaboration. Trauma-informed responses are intentional and relational, not reactive. Resist and re-traumatization. This asks us to examine how our systems, language, and practices may unintentionally recreate powerlessness or harm. We actively work to minimize triggers, avoid coercion, and create environments that promote dignity, safety, and autonomy. Together, the four R's remind us that trauma-informed care is not about treating trauma directly, it's about changing how we show up so healing becomes possible. Trauma-informed care uses non-judgmental, empathetic language. We avoid assumptions about someone's history and instead remain curious and respectful. This is where the shift happens and becomes visible in our practice through language that can either create safety or shut it down. Trauma often involves a loss of control. Offering choices, even small ones, help restore agency. This might look like allowing someone to choose the pace of a session, where they sit, or whether they want to talk or pause. Choice communicates respect and empowerment. Trauma lives in the body and nervous system. Bright lights, loud noises, or chaotic spaces can activate threat responses. Trauma-informed environments consider sensory needs by offering calm, predictable, and adjustable settings whenever possible. Active listening means slowing down, not interrupting, and truly hearing what someone is saying, verbally and non-verbally. Active listening validates experience and helps individuals feel seen and understood, which is essential for trust and regulation. Trauma-informed care includes caring for the caregivers. Ongoing training, supervision, and self-care practices help prevent burnout and vicarious trauma. Regulated helpers are better able to support dysregulated systems. Finally, de-escalation techniques. When distress escalates, trauma-informed care prioritizes safety over control. Instead of punishment or coercion, we use grounding, calm presence, and co-regulation to reduce re-traumatization and restore a sense of safety. Overall, trauma-informed care looks like intentional kindness, shared power, and nervous system awareness woven into every interaction. Let's take a look now at the literature on this topic. Judith Herman's seminal book, Trauma and Recovery, published in 1992, reframes trauma by placing it in the context of interpersonal violence, including domestic abuse, sexual violence, and political terror. This was a critical shift away from viewing trauma solely as an individual pathology. One of her most influential contributions is the idea that recovery from trauma happens in stages rather than through a single intervention. She outlined three key phases. First, establishing safety, both physical and emotional. Second, remembrance and mourning, where traumatic experiences can be processed and meaning made. And third, reconnection, which involves rebuilding relationships, identity, and a sense of agency. Herman's model continues to shape trauma-informed care by emphasizing that healing must be paced, relational, and grounded in safety, principles that remain central to trauma-responsive practice today. Bessel van der Kolk significantly expanded our understanding on how trauma lives not just in memory, but in the body and brain. In his influential book, The Body Keeps the Score, published in 2014, van der Kolk brought together neuroscience, psychology, and clinical practice to show how traumatic experiences alter brain functioning, particularly in areas related to emotional regulation, memory, and threat detection. His work highlights how trauma can disrupt the balance between the thinking brain and the survival brain, leaving individuals stuck in patterns of hyperarousal, shutdown, or emotional dysregulation. This helped explain why traditional talk therapy alone is often not enough for trauma survivors. As a result, van der Kolk emphasized the importance of body-based and bottom-up therapies such as yoga, mindfulness, somatic approaches, and EMDR. These interventions help regulate the nervous system and restore a sense of safety and connection within the body. His contributions shifted the field toward a more holistic, integrative approach to trauma treatment, one that honors the inseparable connection between mind, body, and nervous system. Sandra Bloom is a psychiatrist and founder of the Sanctuary Model, which focuses on bringing trauma-informed principles into entire populations, not just individual therapy. The Sanctuary Model was developed for mental health, residential, and community-based settings. Rather than asking only how trauma affects individuals, Bloom asked how trauma impacts systems, cultures, and workplaces. Bloom emphasized that organizations themselves can become traumatizing if they rely on chaos, control, or lack of transparency. In contrast, trauma-informed organizations intentionally create environments grounded in safety, emotional intelligence, shared values, and healthy relationships. The Sanctuary Model promotes consistency, shared language, and collective responsibility for well-being. This approach helps reduce burnout, improve staff retention, and create spaces where both clients and providers feel supported. Bloom's work reminds us that trauma-informed care is not just a clinical skill, it's a cultural and systemic commitment to safety, trust, and healing. Mary Ellen Copeland is a prominent mental health researcher and educator who has made significant contributions to the field of wellness and recovery. Her most influential work is the development of the Wellness Recovery Action Plan, or WRAP, a structured, self-directed approach designed to help individuals manage their mental health and maintain stability. WRAP guides clients in identifying personal wellness tools, recognizing early warning signs, and creating a clear plan of action to support their ongoing wellness. Although WRAP was originally developed for recovery from mental illness, it strongly aligns with trauma-informed principles by emphasizing safety, choice, and control. By encouraging clients to build a plan based on their own experiences, WRAP supports empowerment, self-awareness, and resilience, making it a valuable tool for individuals who have experienced trauma. Vince Felitti and his team of physicians and researchers are best known for their groundbreaking work on the Adverse Childhood Experiences Study, or ACE, published in 1998. This landmark study explored the relationship between childhood trauma and later life health outcomes, revealing how common early adverse experiences are and how profoundly they affect physical and mental health across the lifespan. The ACE study demonstrated that exposure to childhood trauma significantly increases the risk of a wide range of health problems, including chronic disease, mental illness, substance use, and premature mortality. As a result, their research has been instrumental in shaping trauma-informed policies and practices across healthcare, education, and social services, emphasizing prevention, early intervention, and the need to address trauma as a central factor in overall well-being. Patricia Resnick is a psychologist and leading trauma researcher who developed cognitive processing therapy, or CPT, an evidence-based treatment for post-traumatic stress disorder. CPT focuses on helping individuals identify and challenge unhelpful beliefs related to trauma, enabling them to reprocess traumatic events and reduce symptoms such as avoidance, guilt, and distressing thoughts. Her work has significantly advanced the field of trauma treatment by providing a structured, research supported therapeutic approach that has been widely adopted in clinical settings. As a result, CPT has become a key component of trauma informed practice, influencing how clinicians understand and treat trauma across diverse populations. Laura van der Noot Lipsky is a leading voice in the field of trauma stewardship. She is best known for developing the concept of trauma stewardship, which highlights the impact of secondary trauma, compassion fatigue, and burnout on caregivers and professionals who work with trauma survivors. Her work emphasizes the importance of self awareness, ethical responsibility, and sustainable practices for those in caregiving roles. By focusing on how trauma affects helpers, not just survivors, Vandernoot Lipsky has shaped trauma-informed approaches within organizations and professional settings, encouraging systems to prioritize staff well-being, resilience, and long-term sustainability. Moving on to different modalities that are utilized in the treatment of trauma, eye movement desensitization and reprocessing, or EMDR, facilitates the processing and integration of traumatic memories using bilateral stimulation. This approach supports adaptive information processing, allowing memories to be restored in a way that reduces their emotional intensity, vividness, and physiological activation. Somatic experiencing, or SE, views trauma as dysregulation in the nervous system rather than the event itself. It focuses on helping clients track bodily sensations to identify states of activation and settling. Through titration and pendulation, SE supports the gradual release of survival energy without overwhelming the client. This process strengthens self-regulation and capacity for safety, reducing trauma symptoms over time. Somatic experiencing emphasizes restoring the body's innate ability to complete defensive responses and return to regulation. Mindfulness-based practices and yoga support nervous system regulation by shifting attention to present moment experience, particularly bodily sensations such as breath, muscle tension, posture, and movement. This helps counter the trauma-driven tendency toward dissociation or hypervigilance. These practices are typically introduced in gentle, choice-based, and paced ways, allowing clients to remain within their window of tolerance while gradually increasing capacity for emotional and physiological activation. Cognitive processing therapy, CPT, a form of cognitive behavioral therapy, focuses on identifying and restructuring trauma-related beliefs that maintain distress, including self-blame, guilt, shame, and rigid assumptions about safety, trust, power, and control. By helping clients examine and modify these beliefs, CPT supports emotional regulation, symptom reduction, and restored meaning making. Trauma-informed practice is not about selecting a single best therapy. Instead, it involves understanding the individual needs, history, and readiness of each person, and matching interventions to the person in a way that promotes safety, choice, and empowerment. Turning now to implications within and across practices, we see the implication for trauma-informed counseling makes emotional and physical safety first priority. This means creating an environment where clients feel secure, respected, and supported. It also involves being mindful of triggers, pacing the work appropriately, and clearly explaining what to expect during sessions. Safety is not just about the physical setting, but also about establishing trust, consistency, and predictability. Another key element is the use of regulation tools. Teaching and practicing skills such as breathing exercises, grounding techniques, and pacing strategies helps clients manage overwhelm and return to a calmer state. These tools can be used both in session and as daily practices, empowering clients to self-regulate when distress arises. Finally, trauma-informed counseling emphasizes empowerment and collaboration. Rather than directing the client or imposing a plan, the therapist works alongside the client, inviting them to make choices, set goals, and take ownership of their healing journey. This collaborative stance helps restore a sense of control and agency that trauma often disrupts and supports long-term recovery. In trauma-informed education, it's essential to create predictable and calm environments. Students who have experienced trauma often feel unsafe in chaotic or unpredictable settings. So, routines, clear expectations, and a structured classroom atmosphere can help them feel more secure and able to learn. Calm, consistent leadership and a steady pace also reduce stress and support emotional regulation. Another important implication is to respond to behaviors as communication. When a student acts out, withdraws, or becomes disruptive, these behaviors are often a signal of unmet needs, such as fear, overwhelm, sensory overload, or difficulty with emotional regulation. Instead of viewing behavior as bad or intentionally defiant, educators can ask, what is this student trying to communicate, and what supports do they need right now? Finally, trauma-informed education emphasizes the need to foster belonging and connection. Positive relationships with teachers and peers can create a sense of safety and trust that supports healing and learning. Building a classroom culture where students feel seen, valued, and supported helps counteract isolation and reinforces resilience. Finally, for organizations, a trauma-informed approach begins with staff training and supervision. This means ensuring that everyone, from frontline staff to leadership, understands the impact of trauma, recognizes common trauma responses, and knows how to respond with safety and empathy. Ongoing supervision and support are also essential to help staff process the emotional load of working with trauma, prevent burnout, and maintain consistent, compassionate care. In addition, organizations must build trauma aware policies and language into their systems and culture. This includes using respectful, non stigmatizing language, creating procedures that prioritize safety and choice, and designing services that reduce re traumatization. Trauma aware policies might involve flexible scheduling, informed consent practices, and clear pathways for client feedback and complaint resolution. By embedding trauma informed values into policies, organizations can create environments that support both clients and staff in a sustainable way. Looking now at therapist self care and self awareness in this field, we understand that this work asks a lot of us. Vicarious trauma and burnout are real risks. Trauma informed care includes the caregiver. Boundaries, reflective supervision, and self regulation are ethical necessities, not luxuries. When we model regulation, presence, and self compassion, we become part of the healing environment. And we know that trauma never exists outside of culture, history, or systems of power. Ethical trauma informed care requires humility, consent, and cultural responsiveness. We must acknowledge historical and collective trauma, especially in Indigenous, racialized, and marginalized communities, and honor healing practices rooted in culture, community, and relationship. Okay, here are some key takeaways from this presentation. Trauma-informed care is fundamentally centered on safety, empowerment, and connection. It is built on the understanding that trauma can inform how people experience the world, relate to others, and feel safe in their environment. Therefore, creating a sense of physical and emotional safety is essential, while also supporting clients' autonomy and decision-making. Connection through trust, empathy, and relationship is equally important as it helps rebuild a sense of belonging and stability. Effective trauma care requires an integrated approach that addresses the mind, body, and relationships. Trauma affects both neurological systems and emotional functioning. So, treatment should include strategies that support cognitive processing, nervous system regulation, and relational repair. This may involve therapeutic interventions like EMDR or CPT, as well as body based practices such as mindfulness, yoga, or somatic experiencing, depending on the client's needs. Finally, practitioners must commit to ongoing self-awareness, cultural humility, and ethical sensitivity. This means recognizing one's own triggers, biases, and limitations while continuously learning from clients' lived experiences. Cultural humility involves respecting diverse backgrounds and understanding how trauma is shaped by social, historical, and cultural contexts. Ethical sensitivity requires that practitioners prioritize consent, boundaries, and the client's well being in every decision. Together, these qualities support truly trauma informed practice that is respectful, safe, and responsive. Okay, so I invite you to reflect on these questions or others that you may have in our Brightspace forum, and I will be posting these particular questions in each day of our Brightspace discussion. So thank you very much for attending this presentation and for your interest. I've included the references in the last 2 or 3 slides that you can view in the PDF version of this presentation, which I will post in Brightspace. Thank you very much, and we will see you in the learning platform.